Yes, we were deeply involved in COVID-19 management from the first flight from Wuhan, then in north of Italy, and then in our intensive care in Rome. But I decided to try to come back to the normal world and try to speak about something that is very interesting for military doctors, so about trauma. This is our hospital. We are in a very good place in Rome because we are just near the Colosseo, so it's a really amazing place. I would like to start rapidly, and today I would like to spend not more than 15 minutes to discuss with you and to have your point of view. This is a typical flow chart about what we can do in our trauma patients, and I would like to underline 4 points. Sorry, the fact that sometimes in our overseas operation we don't have any point of care test available, that sometimes the evacuation is not available in a short time. So we have to consider alternative solution, and we have to pay attention to the timing about our actions. As you can understand, the time is a vital resource, is a very limited resource, so it's very important to match with time. And Professor Estridge is a colonel, a US colonel of the reserve, is the chief of the emergency surgical department in Sant'Antonio, wrote in this paper that, well, the golden hour is an important concept, but sometimes we have to act quickly. And it shows that after 15 minutes from a very high a trauma with a very high severity score, after 15 minutes, the percentage of casualties that are going to survive decrease completely. This is the Kaplan-Meier that show the fact, yes, well, we didn't have to wait a study, a paper to understand that quicker the better. But we have to remember a very important point, for example, that coagulopathy arrives in our casualties despite intervention. What I mean? I mean that a quarter of our patients, even we are treated well, so we are going not to give so much fluids, we keep warm the patient, a quarter of those patients develop an acute coagulopathy in arrival in ER. And we can show in the slide shows that more higher is the injury severity score, more higher is the percentage of coagulability that is going to develop. And maybe the fact that we have a disease sooner after the trauma, maybe is due to the fact that we have a very high oxidative stress that impact even in the organization of the fibrinogen. So we have to remember that the timing is very important in those quarter of patients that are going to bleed very much, too much. So we have to pay very much attention. I will speak about this slide later, but we have to remember that we have almost a third of our casualties in overseas operation that could survive if we could have more attention. But why today people, as Brody is writing here, still dying? Because if we did a lot of improvement, as you can see, in the pre-hospital setting, but after the 24 hours, trauma patients are going to die still too much. And it's a big problem because there are a lot of syndrome about inflammation that due to the oxidation stress that we are not going to face very well. Now, the London Air Ambulance Service started to have blood on board. But the main point is when we work overseas in austere environment, are we able to carry blood, platelets, and plasma? This is a very important point because it's a logistic challenge. Then we can try to understand who is the patient that maybe is having an internal hemorrhage. We can do a micro challenge of fluid and to focus on those patients that are no responder about the blood pressure. We can try with our scores, but we have to find easy scores to apply, because if the score is too difficult to apply, as human and anesthesiologist, I'm not going to apply it. I'm not a surgeon, so I'm very easy when I'm going to the patient. So I need something easy in the worst situation. So the patient that is bleeding in the middle of a desert. Maybe the shock index could help us, and when the cutoff under 0.9 is a very good index, and obviously is very easy for us as anesthesiologists. And this is another interesting paper. It's an old paper 2012, but I think that it could help us to change the paradigm. We start to understand, to consider hypotension under 90. Now, maybe when we speak about trauma with very high injury severity score, we have to move this cutoff up to 100, because other slide shows under 100 we have an increase of base decifit and a very increase of mortality. So as the patient is going to keep its reserve, and when we overpass this limit of 100 of systolic pressure, we have all the decompensation in the patient. So we have to understand even this new point. I don't focus on this because it's very we are all aware about our patient care. And this slide about golden hour, I think, is a stone, is a very important stone, is 2015 on JEMA. And what we see here, we see that after the US Defense Secretary mandate that assess that all the casualties need to arrive in a surgical room, not beyond 2 hours as NATO described, but not beyond 1 hour, then we see that the black point decrease is the casualty fatality rate. So when the patient reach a medical treatment facility in 1 hour, we have an increase of we have a decrease of mortality. So the golden hour is not philosophy, but is a really effective concept. We have also to assess and say that the fact to let the patient, the casualty, reach a medical treatment facility in 1 hour is a very, very logistic and personal effort, because in that case, they had to spread all over Afghanistan, for example, helicopters and a forward surgical team. But it was effective in the mortality. And about blood, I will speak better about blood later, but it's interesting that when we speak about hypotensive resuscitation, we have to consider the time, because we have to understand that how long can I take a patient with a very low blood pressure? So the fact is that we have to maintain hypotension and give soon blood products when we have, and not to wait. And moreover, I can show later, I'm sorry, we have to consider the working blood bank. So to give whole blood, and about this topic, I would like that all the colleagues that are today gave their impression or their point of view. In Italy, we are not allowed to give whole blood, only for self transfusion, for example, after a scheduled surgical treatment. I'm going to give my blood, and they are going to give me it back. But about whole blood, we are not prepared. The law doesn't allow us. That is an interesting solution, because we are giving concentrate blood. We are giving blood with high hematocrit without all the factors, with all the factors that we need about coagulation, fibrinogen, and so on. And as you can understand there, well, and we don't have any anticoagulant in our whole blood pack. So I think that is an interesting point of view. And Colonel Shackelford, she's a US colonel, and wrote that there was a very dramatic difference in casualties that received blood on board in helicopter. I'm so sorry. Sorry. But not only between among patients that received blood or that they didn't receive blood, but there was a difference even about the timing. What I mean that casualties that receive blood on board not beyond 15 minutes, they had a very better outcome. So even here, the timing is very important. Even about the timing could be interesting, the use of lyophilized plasma. Here we have very important trials, the Pamper and the Combat. They had different conclusions, but Lancet say that the different conclusions, so the one was effective, in the other trial was ineffective. The conclusion was that it depends on the length of the transportation. So maybe here in Europe, for example, in Italy, we have very short transportation, even helicopter. So there is not a big space for lyophilized plasma. But when you have a very big distances to cover, maybe it could be a feasible solution. And lyophilized plasma is very useful because you can storage at normal temperature, so you don't need a minus 80 degrees in the refrigerator, and you can have the plasma in 6 minutes with saline. So I think is a very feasible solution. In plasma we have fibrinogen, and here the very important study from Megale showed that pre-hospital fibrinogen in trauma patient in hemorrhagic placing is a very good solution. And when I asked to Professor Megale how many fibrinogen I have to give to our casualties, I'm speaking about hemorrhagic casualties, he said even 10 grams, because even you're going to give 10 grams of fibrinogen, when you will reach the emergency room, you will test that the fibrinogen is very low. And in this very colored slide, and I'm not sure it's not Italy, because as you well know, in Italy you had we were divided in color by region, so we had red, yellow, and orange region during COVID-19 pandemic to understand the risk of each zone and what we could or we couldn't do. Here we can understand that fibrinogen is very related with base excess. So I can understand when I have base excess or hemoglobin, how low is my fibrinogen. So I think it seems complicated, but the end is a very interesting slide, and I would like to focus not in the patient that is very good, so base excess more than 2, or in patient that is a minus 10 of base excess that we cannot really understand and easily understand is a very critical patient, but the gray zone, -2, -6, what is happening? And there we can understand the critical fibrinogen that we could face in those cases. So what I mean when I say the gray zone, sorry, slides, I'm speaking about the occult shock, because when I'm overseas, I have to pay attention not to the healthy patient, not to the very critical ill patient, because I'm going to evacuate him soon, but I have to understand the patient that has a blood pressure 90 or 100. What can I do? So I have to monitor to understand if I have a occult shock, because we speak about young men, young soldiers, they are very fit, so they have a big physiological reserve. So I have to understand if the patient, for example, has an internal bleeding that I am missing. So I can use, for example, the continuous non-invasive hemoglobin monitoring, for example, or, for example, the NIRS solution. When I'm speaking about TBI, so to understand if the patient has a great problem that I cannot monitor, and this technology could help us to do that in the right timing. Even, for example, the renal index is very easy to calculate with an ultrasound that now is common to have in our forward surgical team or in our role 1 or role 2. Or we could continue with two extreme measure. Extreme measure, I am speaking about REBOA. So the English and the US are developing a very important capability, and with the REBOA I can give a bridge to the patient that maybe could not wait even for the golden hour. This is an easy flow chart about the REBOA display. I could give the last three slides. This is how the French do it. The French do it better. I'm joking, but our French friend, they develop a capability to shoot the blood, and it's feasible and it's not very expensive. And they have a very interesting program to transport whole blood from France to the Sahel operation, to Operation Barquet. And this is an Italian medic that provide in Iraq a homemade system to do a self-transfusion from an hemothorax. Important thing that the patient survived without any big problem. But this was a very clever idea to do in a very austere environment. Last thing is the ALM, adenosine lidocaine magnesium, is still under study in Australia, and could be amazing, could be a miracle drug, because it seems to be really effective on hemorrhage and in rats. We will see in the future what we have to find. So I would like to finish saying that golden hour, yes, we have not all the time the chance to wait for 1 hour, but I think that the golden hour is a very important paradigm to have a timing framework in which we have to work and to try to develop new solutions, as for example the 10 platinum minutes that was even written by the NATO in the manual. So I thank you for attention, and sorry that if for my English, first of all, and if I was boring. Thank you very much.
My friend Nadir, thank you. Your English were really good and you were not boring at all. Actually, it reminds me 3 years ago, when we had physical meetings, I went to some hospitals and we had some speeches. And one question that I had is that what is the reason of the IMIHO project? What we are doing here, because there are a lot of medical journals, there are a lot of, better professionals than us in our fields. I'm not a medical officer, I'm an IT officer, but I'm speaking about you. And why should we have this initiative? My answer to them is that the medicine and the scientific data and all the practices could be the same. The difference that the military do is the circumstances. Sometimes we do not have the luxury of being in a nice white room, clean room, when we have all the time and all the, not the time, let's say the time is the same. We have nice equipment, we have, you know, quiet, sometimes you are in the battlefield, you have bombs or gunshots going around you, you have to deal with a lot of situations that are making even simple procedures much more difficult. I'm not an expert in this subject, but you and other colleagues who have shared in peacekeeping equipment missions and abroad in some places that unfortunately are still under conflict, I think you understand what I'm saying. So one of the how say outcomes and one of my visions for this project is to bring these people together who have been in under very stressful and difficult conditions, and they have to do improvising like you saw in your slide, or sometimes even other extraordinary circumstances to do their job. Also, I would like to add something that I saw regarding forwarding medical supplies to the front lines. There is a program, I think, in the US to have drones, you know, these delivery drones that you are using for pizza and other things. Amazon and some other companies are starting very slowly to incorporate this. So there is this program to have these delivery drones to give, you know, even under fire, medical supplies directly to the front lines. This is something that I read. I'm not an expert, and I don't want to say too much. Thank you again for the presentation. I would like to give the floor to everyone who would like to ask some